Good morning, everyone. Myself, Dr. Anita Chalak. I am Professor and Head Department of Biochemistry at Jawaharlal Nehru Medical College, Savangi, Wardha. As part of obesity reviews, I'll be presenting my topic on metabolic changes in obesity. Before I go for presentation, let us first have to understand what obesity is. Is it an excess weight, overweight? No, not always necessarily. A lean person with very high muscles may have excess weight without having adiposity. So the weight can be due to muscles as well. Then what is obesity? Obesity is the state of excess adipose tissue mass. The fats or the lipids which are stored in our body are in the form of triacylglycerols, also called as triglycerides, and they are stored in adipocytes. And whenever required, these triacylglycerols are hydrolyzed into free fatty acids and they give us energy. And that is the reason why humans survive starvation for as long as several months. Prevalence of obesity in Western countries is higher as compared to India, but sedentary lifestyle and availability of high energy rich food has increased the prevalence in India too. There are various factors which contribute to obesity or which regulates the body weight, which includes neural factors, endocrine, genetic, metabolic, environmental, and behavioral factors. Slight imbalance between energy intake and energy expenditure can lead to obesity. With this background, I'll be covering my topic under following headings. Definition of obesity. We'll be discussing its types, how obesity can be assessed, body weight regulation, certain molecules that influence obesity, and metabolic changes in obesity. Obesity is the direct result of overeating, that is excess calorie intake. Or it can be a lack of physical exercise or the couple action of two. Overeating with lack of physical exercise can also lead to obesity. It is said that every 7 calories of excess consumption leads to 1 gram of fat deposition and increase in body weight. It is most prevalent in Western countries. In United States, nearly 2/3 of the adult population are overweight and more than 1/3 of this group are obese. In India, its prevalence is increasing gradually with sedentary lifestyle and variety of palatable, inexpensive food availability. It is not easy to define obesity. Various researchers have given different definitions, and one of these says anyone who is more than 20% above the standard weight for people of the same age, sex, and race must be considered as overweight. But then this weight can be due to muscles or can be due to high density of bones. So obesity can be better defined as that physical state in which the amount of fat stored in the body is excessive. It must be defined by assessing its linkage with morbidity and mortality. Physiologically, there are 2 types of obesities. First one is exogenous obesity, which is overeating coupled with less of physical exercise. There is imbalance between energy intake and energy expenditure. While endogenous obesity depends on the endogenous factors, certain endocrine conditions like Cushing's syndrome, insulinoma, etc. Certain metabolic factors like various hormones, various neurotransmitters regulates the body weight, as well hypothalamic lesion. If there is lesion to the satiety center, it can lead to obesity. Well, pathologically, again, there are 2 types. Hyperplastic obesity, where the adipose cell number as well as adipose cell size is increased and the distribution of fat is central as well as peripheral. While in hypertrophic type of obesity, it's the only cell size which gets increased and the fat distribution is central. Now this diagram shows the process of weight gain. In the initial phase, during weight gain, it is the cell size which increases. But once the adipocytes reach their maximum size, further weight gain is achieved by recruitment of new adipocytes. So pre-adipocytes are differentiated into adipocytes for further weight gain. Further weight gain is achieved by increase in size of these new adipocytes, and this way the process of weight gain occurs. But during the process of weight loss, it is only the size of the cell which decreases and not the number of the cells. Measuring body fat directly is very difficult. There are various indirect means by which body weight can be assessed or measured. The commonest one is body mass index. Besides that, certain anatomic differences in fat deposition, biochemical differences in regional fat depots, size and number of the fat cells can also assess the obesity. Body mass index, as we know, can be defined as weight in kg divided by height in meter square. And the healthy range of BMI is between 18.5 to 24.9. Those having BMI between 25 to 29.9 are considered as overweight, and those having more than 30 are considered as obese, and those above 40 are extremely obese. BMI of 25 must be considered as a threshold since it is associated with various chronic diseases. About 80 to 90% of the fat is stored in the subcutaneous tissue, either in the abdominal cavity, that is upper part of the body, or in the gluteal femoral region, that is the lower part of the body. So if a waist-hip ratio is more than 0.8 in women and more than 1 in men, it is defined as upper body or android type of obesity, while if the waist-hip ratio is less, it is considered as gynoid type of obesity. This picture shows the anatomic differences in the fat distribution. In the first part, the waist-hip ratio is more, and this is a central type of obesity, or also called as apple-shaped obesity, commonly seen in males. While the second picture shows low waist-hip ratio, where the fat is deposited in the lower body part. This is also called as gynoid type of obesity, commonly seen in females. Now, certain metabolic differences in fat deposition. As we know, fat is deposited either in the abdominal region or in the gluteal femoral region or in the visceral adipocytes in the form of triacylglycerols. Now, this is very interesting. The fat which is deposited in the lower part of the body, that is in case of gynoid type of obesity, it tends to mobilize fatty acid more slowly than those from abdominal subcutaneous depots. Or we can say, it is the fat which is deposited in the lower part, it is metabolically less active as compared to the fat which is deposited in the visceral adipocytes or in the abdominal region. So, in the abdominal subcutaneous and the visceral depots, the obese subjects have high rates of lipolysis, and this contributes to increased availability of free fatty acids, leading to adverse metabolic actions. And this explains why android type of obesity or apple-shaped obesity is more harmful and is associated with higher risk as compared to gynoid type of obesity. Adipose tissue was considered as a passive reservoir of triglycerides, but now it is considered as an endocrine organ. Each adipocyte is now considered as an endocrine cell, as it secretes certain hormones like leptin, adiponectin, which regulates the body weight. Leptin, by decreasing the appetite, regulates the body weight, while adiponectin reduces the levels of free fatty acids in the blood and has been associated with improved lipid profiles, increased insulin sensitivity, resulting in better glycemic control. Now, what is the importance of portal circulation? Now, in obesity, there are raised levels of free fatty acids. As well, there is secretion of certain pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin 6, etc. Now, these free fatty acids and cytokines, which are released predominantly from the abdominal subcutaneous fat as well as the visceral adipocytes, they directly enter the portal vein and have direct access to the liver. And in the liver, this leads to increased hepatic synthesis of triglycerides, leading to hypertriglyceridemias. And this is the reason why in obesity there is hypertriglyceridemia. While in case of gynoid type of obesity, this fat enters the general circulation and is oxidized and is utilized. There are various factors which regulate body weight, which include certain genetic factors, environmental factors, etc. But a body weight of most individuals tend to be relatively stable over time. And the hypothesis has been made that individual has biologically predetermined set point for body weight. Whenever there is weight loss, appetite gets increased and energy expenditure falls. Whereas with overfeeding, appetite falls and energy expenditure slightly increases. This is how body weight is regulated automatically. This figure shows, this blue line shows the body weight. This is the initial body weight, and with the period of forced overeating, the body weight gets increased. But whenever this restriction is removed, it comes back to its original state or the starting weight. Same is the condition when there is forced undereating, the body weight falls, but it comes back to its starting weight as this restriction is removed. So body weight tends to return to initial starting point when the restrictions are removed. Genetic factors also contribute to obesity. Like children who are adopted usually show a body weight that correlates with their biologic rather than adoptive parents. Similarly, identical twins show similar body mass index. This is a picture showing identical twins which show similar BMI. Mutations play important role in regulating body weight. Single gene mutations can really cause obesity. There are many genes which has been identified in humans, like gene for leptin called as OB gene and gene for leptin receptor as well, which causes hyperphagia and massive obesity. Besides that, mutations in the gene encoding pro-opiomelanocortin cause severe obesity through failure to synthesize alpha MSH, which inhibits appetite. Some genes has also been identified in rodents like TUB gene and FAT gene, which has a role in body weight regulation. Similarly, environmental and behavioral factors also play important role in obesity and body weight regulation. Certain environmental factors such as ready availability of palatable, energy-dense foods play a role in the increased prevalence of obesity. Sedentary lifestyle, which is encouraged by TV watching and using automobiles, etc. Less of physical activity also has enhanced the tendency to weight gain. Even the eating behaviors such as individuals' unique food preferences and number of people present during eating also influence the food consumption. But it is important to note, in the similar environment, many individuals do not become obese. And what can be the cause for this? As there are multiple factors, certain genetic factors, metabolic factors, endocrinal factors, environmental factors, this can be one of the reasons why only few individuals gain weight even after overeating. Now coming to certain molecules that influence obesity. There are certain signals, long-term as well as the short-term signals. Long-term signals reflect the status of triglyceride stores, and amongst these comes leptin and insulin mainly. Leptin is a peptide hormone secreted by adipocytes, and it depends on the proportion of the size of the fat stores. More the fat stores, more will be the leptin secretion. When we consume fewer calories than we need, body fat declines and the leptin production will also decline. Insulin, as we know, it is a hormone, it is a hypoglycemic hormone which regulates the blood glucose level. It is required for the uptake of glucose from the cell as well as uptake from the blood. And this mechanism or this process is important for availability of energy for daily functioning and to maintain the normal levels of circulating glucose. Now in obesity, these insulin signals are sometimes lost and no longer able to control the glucose levels. And even the insulin receptors are at fault in case of obesity. So these individuals are unable to control the glucose levels, leading to hyperglycemia and development of type 2 diabetes mellitus and metabolic syndrome. In obesity, various factors are responsible for insulin resistance. The first one is insulin itself. By inducing receptor downregulation, it leads to insulin resistance. Free fatty acids are excessive in obesity and they are capable of impairing insulin action. Similarly, intracellular lipid accumulation leads to insulin resistance, and certain peptides like tumor necrosis factor alpha and interleukin 6 as well adiponectin, resistin, etc. have altered expression in obese adipocytes and are capable of modifying insulin action. Certain short-term signals are from gastrointestinal tract, which control hunger and satiety. These includes mainly ghrelin, which is an orexigenic hormone, which is an appetite-stimulating hormone. It is secreted when there is absence of food intake, that is in between meal, and it in turn increases the appetite or stimulates the appetite. As the food is consumed, certain other gut hormones are secreted like cholecystokinin, peptide YY, which induce satiety, and this is called as an orexigenic effect. Besides this, hypothalamus also secretes certain neuropeptides such as neuropeptide YY, alpha MSH, which regulates satiety. Certain neurotransmitters like dopamine, serotonin are also important in regulating hunger and satiety. So there is an interaction between long-term and short-term signals which actually leads to body weight regulation or obesity. Now this picture shows the undernourished and overnourished state. The first diagram shows the undernourished condition where there is secretion of ghrelin mainly from the stomach, and it sends the afferent signals to the hypothalamus, and it stimulates the feeding center in the hypothalamus, resulting in increased appetite and decreased energy expenditure. While in case of overnourished individuals, various other hormones like insulin from pancreas, leptin from adipose tissue, cholecystokinin, peptide YY from intestine, they send the signals, they are secreted and send the signals to the hypothalamus, and they stimulate the satiety center, resulting in decreased appetite and increased energy expenditure. Now, little about adipose tissue. There are two types of adipose tissue in humans. White adipose tissue, which is metabolically less active, and brown adipose tissue, which is metabolically more active, as it contains more number of mitochondria and cytochrome, but it has low activity of ATP synthase. This means in mitochondria, the oxidation is uncoupled with phosphorylation. So whatever energy intake is there, it is converted into heat, and this process is called as thermogenesis. It dissipates energy in the form of heat and thus blocks the formation of ATP. So those individuals who are having brown adipose tissue in them are fortunate to have it, as whatever they take, whatever is the intake, it is converted into heat and not stored as energy. This brown adipose tissue is absent in obese individuals, and this explains why only some of the overeating individuals become obese. Now coming to metabolic changes and biochemical profile in obesity. Lipid parameters are the one which are most commonly affected in obesity. This includes raised levels of free fatty acids, increased cholesterol levels, and increased triglyceride levels. The primary metabolic effects of obesity include dyslipidemias, glucose intolerance, and insulin resistance. Now, what is the mechanism behind this deranged lipid profile in case of obesity? To understand this, one must know the role of hormone-sensitive lipase. This is an enzyme which cleaves triglycerides into free fatty acids, which converts triglycerides into free fatty acids, and hence more free fatty acids are available which can enter the bloodstream and can enter the liver, leading to increased synthesis of other lipids like triglycerides and cholesterol and even fatty acids. Now, what is the role of insulin? Insulin actually inhibits this hormone-sensitive lipase. And by inhibiting this hormone-sensitive lipase, it inhibits degradation of triacylglycerols into free fatty acids and hence lowers the levels of free fatty acids in the blood as well as its entry in the liver. Now, since in obesity, the insulin resistance is there, as well insulin receptors are not functioning well, the inhibitory action of insulin on a hormone-sensitive lipase is impaired, and hence more and more active hormone-sensitive lipase is available, leading to more and more hydrolysis of triglycerides into fatty acids and availability of more and more fatty acids in the blood, leading to hypertriglyceridemias. So, in obesity, there is decreased sensitivity of peripheral tissue to insulin, as well there is decrease in insulin receptors in some cases. And this leads to impaired inhibition of hormone-sensitive lipase by insulin. And this lead to more and more hydrolysis of triacylglycerols into free fatty acids and more availability of free fatty acid, which is mobilized from the adipose tissue. So there is increased circulatory free fatty acids, and these free fatty acids are carried to the liver in excessive amounts, and in the liver these gets oxidized, producing excessive amount of acetyl-CoA. And as we know, acetyl-CoA is the precursor for cholesterol synthesis and fatty acid synthesis, and hence TG synthesis. And this is how in obesity there are raised levels of cholesterol, raised free fatty acid levels in the circulation, and raised levels of triacylglycerols, that is hypertriglyceridemias. So deranged lipid profile is seen in case of obesity. This graph shows the correlation between body mass index and the lipid levels. As the body mass index increases, the triacylglycerol levels are increased, as well the cholesterol levels are increased, while the HDL cholesterol levels, which are considered to be good cholesterol, is lowered. So obesity is correlated with an increased risk of death. It is a risk factor for a number of chronic conditions like type 2 diabetes mellitus, dyslipidemias, hypertension, heart disease, etc. The relationship between obesity and associated morbidities is stronger among young individuals. As the age grows, as the person grows, this relationship gets weakens, and beyond the age of 75, there is no such relationship. Weight loss in obese individual leads to decreased blood pressure, decreased serum triglyceride levels and blood glucose levels, whereas raised HDL levels. This slide summarizes the assessment of body fat and accumulation of body fat. So to summarize, body fat can be assessed mainly by measuring the body mass index, which is calculated by weight in kg divided by height in meter square. If it is less than 20, it is underweight. If it is between 20 to 24.9, it is considered to be normal range. If it is 25 to 29.9, it is overweight. If it is more than 30 but less than 40, it is obese, and more than 40, it is considered as extremely obese. But one should note that 25 must be considered as a threshold, as beyond this, individuals having above this or BMI above this are associated with various morbidities. Similarly, the location of body fat also is important. As I said, abdominal obesity is more dangerous than waist obesity. So those who are having apple type of obesity or android type of obesity are at higher risk of mortality and morbidity as compared to those who are having gynoid type of obesity. The fat accumulates in the body as a result of imbalance between energy intake and energy expenditure. Little imbalance, if there is more of energy intake than energy expenditure, it leads to weight gain. There are various factors, as I explained earlier, which influence body weight. There are certain genetic factors. Various genes has been isolated in humans, like OB gene and gene for POMC, as well gene for leptin receptors. Various genes are also isolated in rodents, which has a role in regulation of body weight. Certain chemical factors, like certain hormones, certain neurotransmitters, like leptin, serotonin, dopamine, ghrelin, cholecystokinin, alpha-MSH, insulin, etc., also play important role in body weight regulation. Besides that, environmental factors and behavioral factors are also important in regulating body weight, like availability, cost, taste, variety and energy density of food, portion size, snacking, increased use of automobiles, energy saving appliances, etc. Besides that, psychological and emotional response to food is also important in maintaining your body weight. So to conclude, overweight and obesity are major health problems associated with increased risk of diabetes and numerous other illnesses. The available pharmacological treatments are poor. Surgery can be useful, which again is applicable only for patients with significant obesity. Future development of new therapies can be hoped for. There should be a paradigm shift in viewing obesity as a disease requiring treatment rather than deferring treatment until the complications develop. So the take-home message is, as obesity is a result of various factors including neural, genetic, metabolic, environmental factors. Most of these we cannot alter, but at least certain environmental factors and behavioral factors we can modulate and prevent obesity by saying no to sedentary lifestyle, by introducing regular exercise in our daily routine, by inculcating healthy food habits. And even if there is weight gain, we can think of therapeutic interventions. Thank you.